Dreaming of owning a property in a prime location with great proximity and fantastic neighborhood? EJ Investments Sanyang Seaview Estate is the best choice you have been waiting for. Our Sanyang Seaview Estate is approximately 15 minutes drive away from the busy hub of Brusubi roundabout and into the heart of nature, where you can have a peaceful and relaxed lifestyle with your family. You can buy a finished 4-bedroom story with 5-year flexible payment plan or a service plot with 2-year payment plan option. With over 300 homes, you will enjoy big tar roads with covered drainage, modern electrification with solar street lights, gated entrance with security post, and a breath-catching experience of our beautiful sea view and lake view. You can own a home today at our Sanyang Seaview Estate. Call us today on 446-4838 or 325-9220. Visit our website on ejinvestments.net. EJ Investments, first in property.
So a very warm welcome to all of you to our second edition of Public Health Awareness Week in the Gambia. The objective of the week really is to raise awareness on the functions of public health and create greater visibility on our achievements as public health professionals, be it in the government or outside the government. Mr. Chairman, the Gambia Association of Public Health Officers is a national, non-governmental, multi-professional organization that brings together public health professionals interested in promoting the welfare of its members and advancing public health in the Gambia. Founded in 1969 in Banjul, GAFO is the only national professional public health association representing and serving the broad area of public health at national, regional, and district levels across the country. Members of the association work in different sectors, including public, private, NGO, some of the colleges and university, and we also have some of our members in the diaspora. Mr. Chairman, during the past 2 to 3 years, GAFO registered some key achievements which I want to list. The first one is the support we provide to members of the association who are in need, maybe in terms of health, or have passed away and they have families left behind. So we've been giving them a helping hand to reach out to them. Even though they are gone, they are not forgotten, and we feel we are still connected. GAFO has been fully involved in the preparation of the public health bill, so it's now enacted. That meaning we now have a public health council which needs to be now set up. So we've been very instrumental in drafting that bill. We are also supporting the review of the Public Health Act, which I understand is going some challenges, but we are determined to work with the Ministry of Health to see that through. GAFO is involved in ensuring quality training and public health practice in the Gambia. So we sit on that panel to interview the students who come to the School of Public Health and to make sure that they are fully baked by the time they leave the college. Last year we supported the Gambia College School of Public Health and renovated their facilities. If you have been there 2 or 3 years ago, you'll be disappointed. This infrastructure was in bad shape, the toilets were horrible. We've invested over $150,000 to provide classroom furniture as well as improve the teaching and learning environment at the college. And still on the school, we are doing our best to try to encourage students to take up careers in public health. With this, we provide up to 5 hours annually to outstanding students in public health, and most of these hours are provided by individuals. So we are very happy that that's happening and will continue to do so. And to a small extent, we try to support some small-scale health promotion activities. You may be aware of the Student Association of Public and Environmental Health at the University of the Gambia. They celebrate this annual road safety campaigns. Dr. Cham, I understand you were there last year. this is powered by GAFA. So we are behind the scene, but we are trying to do as much as possible to do our bit in terms of advancing public health. And one last part that I think is important is what we are trying to do here now, is sort of create a platform for policy dialogue and also for the sharing of research findings. So this is something that GAFA is trying to do. It's new, but it's something that we want the public to get used to. We want our policies and our public health interventions to be evidence-based. Mr. Chairman, Section 2164 under the social objectives of the 1997 Gambian Constitution stipulates that the state shall endeavor to facilitate equal access to clean and safe water, adequate health and medical services, habitable shelter, sufficient food and security to all persons. This is from the Constitution of the Gambia. So what I'm trying to say is that the Constitution is saying that health is the fundamental human right. So this makes it incumbent on the state to provide and protect the health of the population. The policy goal of the National Health Policy 2012 to 2020 is to reduce morbidity and mortality and to contribute significantly to quality of life of the population. Very noble. The Gambia National Health Sector Strategic Plan 2014-2020 provides the sector with the medium-term focus, objectives, and priorities to enable it to move towards the attainment of the Gambia's health policy directions. Two of the guiding principles stated in the National Health Sector Strategic Plan are client satisfaction and skilled staff retention and circulation. Let me quote. Yeah, that's all right. So the National Health Sector Strategic Plan highlights inadequacies in the healthcare delivery system that are linked to limited human, financial, and material resources to meet the growing demand of the health services at national, regional, and community levels. This has contributed to a number of challenges, including the following: high accumulation of skilled health and social workers, inadequate skilled and competent health workers, low staff production from health training institutions, inadequate basic equipment, consumables and other logistics, insufficient drugs and other medical supplies, and weak referral system. These are not my words, these are from the national document. The National Development Plan, NDP 2018-2021, this is Mr. Barrow's leadership, states that although Gambia has registered significant achievements because of improved access to basic health services across the country, primary health care has substantially deteriorated over time and is no longer adequately serving the population. There is considerable growth in non-communicable diseases, high out-of-pocket expenditure for health care, serious challenges relating to maternal and women's health, and skilled health personnel are inadequate. Not my words. This is from the National Development Plan. To address these issues and other challenges of the health system, the NDP promises to make major effort to revitalize primary health care system by building, reorienting, and realigning the health system in the Gambia towards universal health care coverage, UHC, with an emphasis on PHC, and maintaining effective systems to ensure improved financial protection and affordability of the most vulnerable populations, including women, children, and youth, while intensifying focus on quality and equity. One of the conclusions of a recent report by the National Assembly Select Committee on Health, I'm sure Honorable Sila will expand on that. This is one of the conclusions, that the delivery of services is currently compromised by staff shortages, especially for medical and surgical specialists, low salaries and low motivation of available staff, staff attrition, particularly for nurses, and poor attitude of staff, as Bolong indicated, in the public sector. All these factors affect the performance of staff and in turn the quality of services delivered to the population. Thus, adopting strategies to improve motivation of health service providers is vital to improve the quality of care and to address the health service providers' crisis. Those are from national documents. In December 2018, last month, we got a chilling reminder of the deplorable state of our health system and how things have remained the same. You may have read the story. It was published on the Foreign newspaper on their December 5th, 2018 edition. The investigative journalist Kerr reported after visiting rural health facilities in the Gambia under the caption, "When actions contradict policy, horrific healthcare services in rural Gambia." I invited that journalist to join us today, but unfortunately he couldn't join us. But he has allowed me to quote from his article what his findings were. He noted that shortage of beds has hit most healthcare facilities in the Upper River region. Consequently, patients in critical condition, including postnatal mothers, are compelled to use mattresses on the floor to rest after delivery, while only a few trained nurses are available, struggling to give a day-to-day care to patients. The realities of the health provision are unmatched with the National Health Policy 2014-2020 objectives. These are from Kerr. So this is a journalist who is interested in the welfare of our population and has gone as far as URR just to see what is happening. But these are not new to us. We are all aware of this. But this is the reality and it has not changed. So, Mr. Chairman, I'm taking long, but I need to give context why we are having this symposium. In view of the challenges highlighted above, GAFO, in consultation with the Ministry of Health and Social Welfare, has dedicated this year's Public Health Awareness Week to discuss our health system. In this regard, this symposium is organized to bring stakeholders together to discuss the challenges of the health system, of the Gambian health system, and find ways of fixing them. It is our expectation that this symposium will enlighten us on how our health system functions, because most of us tend to look at just one side. I've read so many criticisms of how things are not working well, not taking into account that we have a system. We have those 6 building blocks. So it will enlighten us on how our health system functions and what needs to be done to improve the access to quality and affordable health services in every part of this country. During the week, the School of Public Health, Gambia College, and the Department of Public Health of the University of the Gambia are also organizing a public health fair at Nusrat Senior Secondary School in Bundung. The fair is an open event which is aimed at creating an interactive session for students to interact with public health students and professionals, and also get some career advice because we want students to take up public health as a career. So thank you for joining us.
Thank you very much, Mr. President. I think those messages have gone very well, and I'm sure there is nobody in this room here who will dispute all the messages that you have just imparted now. This is exactly what is happening in the health system.
So without taking much of your time, as we are behind time, I will have the singular honor and privilege to call upon the Director of Public Health Services to make a statement.
This is a week of reflection for us to sort of assess ourselves, whatever we have been doing in the past 1 year. Are there achievements or challenges? We may say we have achieved a lot, but then some of our achievements, to be very honest with ourselves, have started going down. The EPI services, which the Gambian nation have been proud of as second to none in Africa, the indicators have started going down. Can we start asking ourselves why? Why is this happening? And by the time we were achieving this, we have lesser public health officers than now. In institutional or health facilities, which used to be manned by 1 or 2 people, are manned by 5 or 6 officers, public health officers now, but still our indicators have shown that they are going down. Can we reflect what is happening? This is showing that we need to tighten our belts. Yes, we have started doing very well in surveillance. You can see at the surveillance page what our staff are doing. This is not limited to public health officers, of course, but then we are part and parcel of all the achievements. And I would say this is a very good achievement. The other shortcomings may include, and I believe we should be able to overcome them. My advice as head of the cadre is that we need to show more commitment. I'm not saying we are not committed, but then we need to tighten our belts. We need to show more commitment. This is our nation. We don't have to wait for outsiders to come and develop our health sector for us. We need to do it ourselves. So being the case, we have to, at our various levels, show commitment and dedication. And for that matter, discipline. Discipline lacks a lot. And I think that is our major problem. As of now, as one of our key functions, environmental sanitation. At every level, we are being questioned. And for that matter, I have to take a pause to recognize the presence of the National Assembly member, Honorable Usman Silla, who I just remember when I come to this environmental sanitation issue. When we went to the National Assembly, these were questions that we could not answer because our staff are definitely not delivering the services. Everybody would say, they don't just borrow there. We are no longer seeing them. What is happening? This is our function. It's our core function for that matter. But when you visit health facilities, you will recognize that our staff are not delivering the necessary services. Can you believe that? Even last week, as a director, I have to go to the ground to address an environmental health issue. It's not being fair. With the numerous administrative functions we have, we still have to go down to the field because our officers, for one reason or the other, whether they are not aware that there exists a public health law, I cannot understand. And I want to implore on our regional principal public health officers not to be sitting in their offices. We are here to work, and in doing the work, we have to go to the field. That's the only way we can tackle these problems. If you are sitting in your office to enjoy air conditions, you will never know the problems in the field, not to mention the communities. I will not belabor much as we are behind time, but I would want us all to tighten our belts, to deliver services expected of us. I thank you all.
Thank you very much, Director of Public Services, for those encouraging statements. And I think the message has gone down very well. It's a matter of trying to change attitude and ensure that we do what is right.
Ladies and gentlemen, I now hand over the baton to our co-moderators.
Dr. Kabir Cham is a household name as far as health in the Gambia is concerned. He is not only a medical doctor, but a public health practitioner who has served both home and abroad in different capacities, I think, with the WHO. He's going to look at the characteristics of a well-functioning health system, what lessons can be learned from other countries. Welcome, Doctor.
Thank you. Thank you, Mr. Chair. Well, this is typical indicator of the failure of Board of Health. They asked me for my biodata, which I religiously submitted to somebody purporting to be the president of GAFO. And here am I being introduced as a professor of failure of HIV and AIDS in this country. Anyway, thank you very much, and also thanks very much for the earlier speakers. In fact, they have sent signals and also the litmus test why we are here. The Director of Public Health Services, surely his introductory remarks is nothing short of saying that our health system needs radical surgery. And the president of GAFO, when he was making his presentation, I thought, as the second Gambian medical officer of health, what did we do wrong? But what I want to plead with myself and my subsequent presenters is that the litany of problems related to the health system is no secret to any one of us here, especially for those who've been here day before yesterday, and today. What we should be preoccupying ourselves is what do we put in place to fix which is unacceptable. Let me start by my own vision in relation to the problem. The problem is structural, and what hitherto has been done is cosmetic, and there is no way we can get where we are with this type, scope of expensive interventions. The Director of Public Health mentioned the pride of this country, which was the EPI program. In fact, even the then late Executive Director of UNICEF used to frequent this country to learn why do we get it right. And I fully remember in 86, 87, you know, we're using the OPV. And that year we were using 3 doses. Senegal is using IPV. And we had what we call in science natural experiment, i.e. outbreak both in the Gambia and also in Senegal, despite the efficiency of our EPI program. Of course, being a developing country, everybody, no, these guys, they know how to manage cold chain. It was nothing to do with that. It was technical, because as your program implementation is efficient, you will have a cohort of vulnerable children who are vaccinated but not immunized. And then those children act as a pool, as a cohort pool. When they interact with the wild virus, then you have an outbreak. Anyway, short of that, that's not part of what I was wanting to say. Now, let me also try to expand on the structural problem which we have within the ministry. The chairman, the MC, the chairman actually stated, when we talk about health system, we shouldn't be zooming on the Ministry of Health and social welfare. No, it's broader than that. But within that, the Ministry of Health itself is a structural problem, because within the ministry you have two arms. One is administrative, your permanent secretary, your accounts, etc., and the Honorable Minister will act as a bridge between the technical part of the ministry and cabinet. Then you have the technical part of the ministry. These are the guys who think with science to determine that based on innovation, based on evidence, this is the way to go. What has happened? You have the administrative arm of the ministry now taking on technical decisions. And surely, square pegs in round holes, unless you are a body bunker, you will not get any results. All right? So I've been asked to set the scene. Colleagues will get into the details, the usual ritual of the 6 building blocks, which, well, off the cuff, I may not ascribe to, but we'll hear from them. I've been tasked to set the scene. What is health system? How do we say this health system is working and this is not working? And what are some of the elements? So you bear with me, and of course, if you don't understand the language I'm speaking, please interrupt me. I'm a Democrat. So this gives you some element. I want you to just focus on certain keywords. Quality services to all people, when and where, especially the word need. The word need there is critically important because this is what distinguishes equality from equity. If you want to have an impact on your burden, then you must ensure that you are addressing the need of your population. So please keep that at the back of your mind. All people, you're talking about the concept of universal health coverage. And of course it's universal, i.e. I will provide health at the doorstep of the population. But some of my colleagues in Southern Africa will say, oh yes, even in health, there's appetite in health. And I say, but why? We are all equal, but some people are more equal than others. You suffer the same condition, you will be flown to Dhaka or to Malaysia or whatever, and the majority of the Gambians would be somewhere else. Where are we with that? Again, factory. Of course, this is a concept, so it varies from one country to another. Hence, the need and importance of contextualizing whatever concept you want to implement. i.e., you don't see somebody raising a white flag and you say that's peace. In some cultures, the white is equal to red. And in other cultures, red is equal to danger. You understand what I'm saying? So you always have to contextualize. And then, of course, the last bullet point will be a basis for some of my colleagues who will be talking about the building blocks. So, what are the forces which impact on health system? Surely every system will have challenges. And for us in health, you have increased demand for services, and I'm quite sure Jibril will be tight-lipped with his budget. He will tell you, I have 100 dialysis, and you play within that 100 dialysis. This can lead us to some subsequent discussion. And of course, emphasis on the emotive word, best practice. What is best practice to you may be different best practice to another person. Secondly, best practice also needs to be contextual. And this is the difference between project mode and a program mode. With the project, you are controlling everything. You can even predetermine. But with program, it's now getting into its natural equilibrium, and this is where we measure effectiveness. For your project, you measure efficacy. For your program, you are measuring your effectiveness. Then you have stakeholders. And the stakeholders are interested only in two concepts, whether you like it or not. It will be effectiveness, i.e., have I arrived at Serekunda or at Gunju? You set out your objective. Have you realized it? Or efficiency. I'm quite sure Honorable Usman Silla will be interested in this. I give you money, what can you give me back? All right? You're supposed to start the meeting at 10:30 and you start at 1 o'clock. And surely you will never realize your objective, because the duration of your meeting workshop is contingent upon the costed activities in terms of time. So keep that at the back of our mind. Effectiveness and efficiency. We're talking about health system. This too, in passing, it may not necessarily be applicable at this stage of our development. Because even in industrialized countries now, people are moving from general services to individualized support systems. And this is also de facto, this is the premise, the basis of community health. Individual, family, and community. And then, of course, once you focus on the individual, you'll be interested to know the pastoral outcome. That's what you measure. So that's the forces. Now, how does it work? A good health system. Surely, as I said earlier on, with all systems, you will have challenges. Again, how do we meet the complex needs of our clientele? It means a priori, we must know the needs of our clientele. Because if you don't know, there is no way you can either stimulate, catalyze, and or provide services for these people. Efficiency. In terms of efficiency, especially when we're dealing with health, we always myopic within the walls of the Ministry of Health. You have other sectors, education, infrastructure, water, etc. Our role, technically, is to craft messages and ascertain the carrying capacity of other sectors and build a bridge so that those sectors will carry on and the results will be shared by us. So you may not be spending your $100, but you will be leveraging $50 out of that 100 and get results. That's the essence of tapping on other sectors. In terms of bureaucratic rules, this is the challenge where you have a system where you have overtly central planning. Everything is done now, not in Banjul, but I learn now in Koto. So I'm not too sure whether that's development or not. All right? But this is where now you're talking about decentralization. And we have an act. We have a local government act which decentralizes, and there is a niche, a power, and authority at the local level, i.e. the regional level, to take on hand. Are we making best use of that? No, but we have glorified TAC. They call them what? Technical Advisory Committees. And I'm quite sure if you measure what they're doing, it will be different. Now, last bullet point, you're talking about, these are the challenges. Remember, we're running down on the challenges. The eligibility to determine funding. You can have bright ideas, good ideas. If it does not meet my own interest, i.e. the partner or the donor, then I'm not interested. That goes by the wayside. So you need to marry the two, the eligibility determination and also So now, characteristics. How do we determine that a health system is functioning and functioning well? Community-based. That's where the problem, that's where the individuals are, that's where the families are. They are not in your Edward Francis Small Teaching Hospital or Canifing General Hospital. And you challenge Jibril, out of maybe the $100 they get, I'm quite sure $75 or $80 goes to the hospitals. Where is justice? Where is equity? The rest of the population, where are they? Why are they not part of this national cake? So we are all part of the problem because we accept this unfair, unjustifiable situation. Horizontal, this is the old argument. You remember vertical, oblique, etc., etc. It's basically trying to suggest that this projectization of health services and products will give you a short, sharp shock. Just to digress a bit, I'm quite sure, I'm not sure, because most of you are younger. Some of us are now not old, but older. If you recall the Blue Nile Health Project, it was a 10-year project in Sudan at that time, and I think still, the largest man-made lake in the whole world, where you have input from WHO, input from UNICEF, the World Bank, etc., etc. What did they want to show? That if you have concentration of resources, i.e. money, the technique, the people, that is the trained people, and good management style, you're going to yield results. Of course, you don't have to be a rocket scientist to know that if everything is equal, you are bound to have results. Corollary to that, there was somebody who was defining a fool. A fool is somebody who does the self-same thing every day and night and expecting results. Of course you will not get results. All right? So we have proven that 10 years you have all this in place, it will work. But what happens after the 10 years? The funds are withdrawn, people have written their papers, they've got bachelors, they've got masters, they've got PhDs at the expense of your own nationals. And so what? Of course, the communicable diseases will resort, whether it's diarrhea, schistosomiasis, or malaria. So that's the element of the horizontality. And this leads you to movement from MDGs to SDGs. Sustainability. Whatever you want to do, ensure that, yes, I'll be in a position to do it tomorrow and after tomorrow and not today. Support coordinators. And this, I'm quite sure our colleagues will expand on this. This will be bordering on the human resources for health. I mean, if you assign somebody tasks to do, it must be clear what he or she is expected to do. I'm quite sure most of you are being employed without job description, job specification. You don't have PMDS, and I'm quite sure you don't know what PMDS is. It's Performance Management Development System, i.e. you agree with me that over a period of time, this is what you're going to deliver, and these are the objectives, and this is how I'm going to measure, and at the end I'll say, yes, you've done it, no, you haven't done it, where are the weaknesses, and based on that, I develop a training program to improve your competence. That's all what we're talking about. So that's the support. Evidence-based practitioners. You cannot walk into sustainability without evidence and innovation. You can't. That's why science is not static. We're always moving. You need to upgrade yourself. Your system also will not only be catalyzing people, implementers, but no. Those implementers will also generate knowledge for the common consumption. I'm very proud of what is happening now on the surveillance forum. It's just is just impossible. It's just impossible. And this is just about 2 or 3 years short-term training. I mean, the guys are all firing on all cylinders, discovering all diseases, line of action, etc., etc. But of course, naturally, if it goes to the policy level, where you have square pegs and round holes, nothing happens. But I always tell them, don't agitate, but advocate. Okay? There's a difference between being an activist and an advocate. All right? So, and also, we need to, the key word there is continuous quality improvement that enhances the quality of life of the client. Any health system which is not producing that, forget about it. All right? So, what are the key components? There may not be many. Again, the word needs. At least if you don't remember anything, what I've said, neither to, just remember needs. That whatever program you're delivering is addressing the needs of your population. Yes. Improving the health status of individuals, families, and communities. It starts with individual, then you have an aggregate, which is the family, and that's why even in our profession, we now have family physicians. It's critically important. Then, our role, or the role of the system, is to defend or protect the population against threats of their health. Third bullet point, again, this will, I'm quite sure colleagues will delve into this. If you compare the out-of-pocket expenditure, again, this is where you determine whether there is justice in the delivery of our health services. The urban and peri-urban people are catered for, and the rural populace are left to rule. Simple thing, I don't know whether somebody is here from reproductive child health. If you look at the map of this country in terms of antenatal facilities, clinics, it's beautiful from the west to the east. You then use another variable, they call them filter system. Out of these areas of the country, which areas can they deal with complicated delivery? The spots will be lessened. Then you'll have another filter. Which areas in the country where emergency obstetric care is given? 2 or 3. Come on. There is something wrong. All right? So, equitable, remember equity I used, but this is equitable, this is access, this is where now the justice, I'm paying my rates, my rents, and I also have to demand services from the government. This point is absolutely important. Instead of the keyword health provision, providing, delivering, I mean, you guys should be asking that, look, I remember when we did primary health care, when we were introducing it, and some of you who were in the field will remember religiously the 8 elements of primary health care. The guys went to Jinak, I think it was Jinak Kajad. Somebody remember? Jinak Kajad. And you know getting there is not easy. Eh? Now at least you have maybe injured, but during our time, it was a dog kennel. We entered and we found the alkali, the imam, and everybody in dark glasses. Of course, there's a reason why they were in dark glasses. And then, of course, I was leading the team, but always I lead from behind. And the guy ranted all the 8 elements of primary health care as if at all he or she was defending a PhD thesis. And the alkali patiently listened. Patiently listened. I said, okay, that's fine, we've had you. But our problem here is water. So the guy looked at it and said, no, answer. Don't expect me to answer, answer. So, in good community health programming, use that as an entry point, satisfy their needs, and you build that, deliver your 8 elements. So, that's the issue of this last point. Does it make sense? Mr. Chair, I'll be landing soon. All right? Now we move on from the health system to the health care. And quickly, somebody will be talking about that. Please, I mentioned universal health coverage. I'm not too sure it's still universal health coverage. People-centered, i.e., you are not looking at the buildings, you are not looking at the equipment, you are not looking at the supply chain management. It's the people you are doing. The guy is a social animal, so you are basing it on the people. Inclusive leadership. You don't have to act as the prophet. They also have an asset. That's why I am very hyper allergic to this concept of capacity building. I don't believe in it. Each one of us have got some rudimentary capacity. So what you need to do is to strengthen that capacity. It's only the bodybuilders who will not have any capacity. Then for them you build capacity for them. Then this was what I alluded to. In each of the policies, in each and every sector, please talk in your health. And this will add your efficiency. It will also augur well for your effectiveness. And in doing that, then you will have justice. You will be providing everyone access to needy services. The core needs of healthcare transition. Again, a little bit of history. When I saw Mr. Jain on the screen, when we were practicing, we had dresser dispensers, dispensaries, etc., then hospitals. Then later on, as things progressed, the concept of health center came up, where you have integrated health service delivery, preventive, promotive, curative, and rehabilitative. That's the essence we are talking about, trying to move from that unitary basis to the more lateral or horizontal one. These may not be new. You'll argue that, oh yes, we have a health policy, fine. Yeah, but the health policy, with due respect, our documents are living documents. You need to go back. If there is new information, new experiences, you need to really work. Tracking the progress. How many of us will say, okay, I woke up this morning, this has been my objective, target in the day, before I go to bed, to measure whether I have really realized. Tracking progress. Again, somebody talking about the building blocks, we'll talk about M&E here. Transition. I know transition may be an emotive word for this country, but you need to manage the transition. If you don't, then you will be exposing a huge amount of loopholes. Assessments. Again, it may be related to the second one, but here the key word there is readiness. You are preparing to do that. You prepare yourself to do that. Are you ready for the action? What are the triggers which will lead you to that? And surely from pediatrics, because at that point in time, the focus is on the 5 mortality, and even now our indicators are really showing that we are moving from under 5 to above 5. But how about the old age, the geriatrics? We don't have national geriatric services. In fact, before even going to that place, we don't even have national school health services in this country. What are we doing as part of that? Okay? The integration, we mentioned, this is where you have your preventive, promotive, curative, and rehabilitative. And I'm quite sure as Bonifels, you will recall that you have 3 categories of prevention and 7 levels of prevention. Primary, secondary, tertiary prevention. Primary prevention is subdivided into purpose inbuilt. That's where you have your vaccination, you're preventing. And also, I'm a bit emotive using the word health education because I'm not too sure whom they are educating. Because sometimes they say IEC, health education, COMBI, behavioral impact. So there are countries. If you have a child, you name that child different names. The child will not only be confused, but you will also be confused. But that's the second one. And then the third level is curative. That's why the old adage, prevention is better than cure, technically is not correct, because curative is part of prevention, especially for some of us who are in disease transmission or communicable disease control. When you break the transmission, then you will be in a position to address it. And then, of course, the last 2, you have rehabilitation. It can be both physical and also psychosocial. So these are the 3 categories and the 5 levels of transmission. This is second from last slide. These 2 slides are important because we're dealing with characteristics of health system. What are the triggers? The key word there is change. And all of us, if you want to change, you will have resistance. So, systems, because that's what we're talking about, is systems thinking. That's your higher level of analysis, analytical approach. Then you synthesize, put it together, put language, information, and then in terms of contextualization, you need to align. When you do your analysis, some will work, some will not work. Don't bother about the areas which do not work, because you're looking at impact. And then measurement, which will be dealt with later on, the issue of outcome, and the organizational output. This is important. You cannot write a proposal alone. You cannot deliver, provide services alone. It has to be a team approach. And the team must be high performance. And your high performance must be based a priori, what you agree or condemn yourself that this is what you're going to realize, so that you'll be in a position to measure. And then once we're talking about systems, your support systems to facilitate, to ensure that that carrying capacity is there. Evidence-based practices, these 2 are linked. It's like recently when somebody stood at different health facilities, oh, I'm renaming this health facility a district hospital, without even knowing the definition of a district hospital. Okay? And the president cited an example where you're claiming that you have a hospital, but your bed is your floor. So, some of these things we need to ensure that, and in fact, the word to add here is innovation. You also need to be innovative. You need to be adventurous. Things can improve, and things should improve. You cannot be performance-based evaluation. This is what I refer to in the human resource capital. But of course, this will emanate from your policy, your strategic plan, your work plan, departmental unit, and your individual work plan, so that you will be in a position to measure, have you arrived at Sukuda or not? And if you didn't arrive, what made you not to arrive, which you can factor for your subsequent implementation. Value sustainability through innovation. And I tell you, this last, we in the Gambia, we are not doing it. We cannot be in the Guinness Book of Records, because definitely we grumble, we don't complain. this is important. Everybody is resisting change. Our responsibility, moral obligation is to ensure that we overcome this. Of course, there are ways to do it. This is also true as of even today, 24th January 2019. Resist change. Either the guys are overwhelmed doing not what they are supposed to do, or they just don't want to change. But my mantra is, yes, but change is going to come because there is no position which is permanent. I'm not too sure whether you agree with me. So to do that, this slide gives you just an array of activities which you need to, and you might argue, I have a vision, I have a policy, I have a vision, I have a mission, I have blah, blah, blah. But if nothing is working, well, no, that's not right. Something is working. If things are not working in accordance to the expectation, then I think it's good for us to go back. And then communication skills, the issue of multiple stakeholders, the issue of empowerment of your resources, and the issue of linkages, which is also critical. So, again, this will be dealt with, but the key words are continuous quality improvement. And to do that, your M&E must come into place, and this will act as a framework to tell you how far or how near you are of your target. And of course, your results from that process can either be your base, your benchmark, or you can use it for future goals. And of course, both outcome and outputs will be, it's not only, it should not be deductive, but it should be inductive. And this is important. So sitting around the table and developing a quality improvement plan does not really lead you to where you are. And lastly, I want to leave you with the 67 World Health Assembly resolution, and the key words there is strengthening the health system, basing it on the primary healthcare approach to ensure that we advocate that it is at the highest international political agenda. Thank you very much.
Thank you very much, Dr. Cham. I'm sure you will all agree with me that the scene has indeed been set. He has laid emphasis on a number of very pertinent areas as far as the state of the Gambian health system is concerned. Dr. Jan, like I indicated earlier, is the proprietor of AfriMed. I think AfriMed is a household name in the Gambia now. He is one key player in the health sector from the private sector. And I always say that the private sector is a very critical player if we want to ensure an effective and efficient health system in the Gambia. The linkages have to be there. They cannot operate in isolation. And they need government to also recognize that they are not out there to only make profit, but they are there to also serve what Dr. Cham mentioned repeatedly in his presentation, the pressing needs of the Gambian population. Like Dr. Cham, I was not provided with your biodata, and I don't think you need a lengthy introduction. It is now my singular privilege and honor to invite you, Dr. Omar Jan, to deliver on the state of the health system, but of course, like has been highlighted in the schedule, from the point of view of a private practitioner in the Gambia. Thank you.
Good afternoon, colleagues, gentlemen. I would like to take this opportunity to thank the GARCO team and the public health community for allowing me to come and speak on behalf of the private sector. As the introducer has said, I started working in Gambia privately in 2007 when we opened a small place in Senegambia. We stayed there for about 8-9 years and then eventually moved to Brusubi, where we are now. When we started in 2007, there were about 3 or 4 private health clinics who were providing some services. When we came, we found that there's some things lacking. And can you do this? Okay. And then we thought that from the experience we've seen having worked around the world, in UK, where I spent about 10 years practicing in NHS and also in private hospital, we could do a few things. And for the first time, we were able to provide, during the night, 24 hours pharmacy, ambulance service, laboratory service, which people generally in the Congo were having difficulties accessing that. So that was something we brought in at the time. Then by 2010, we found that, well, orders came up, and apart from 3, you have about 8 new private clinics now joining in and working, doing what we do. In fact, at the moment, if you want certain services, for example, echocardiography, most ECGs, mammography, I think ambulance, especially air ambulance transfers to Senegal or other places, you need a private service. So private service importance is quite prominent in our area. Unfortunately, it's more or less limited to the Congos. There are not many behind Brikama. It's all about from, I think, Brikama to Bantu, etc. I will not be giving a long speech. I'd also like people, if they have any questions, they can ask me. What we found when you're providing private service, there are many, many challenges. Number one is energy, the cost of running a generator, because of interruption and poor electric supply. It gets very, very difficult. We're spending, I can tell you, about 3 to 3.5 thousand euros every month just on fuel, so that we can get our generators, the theaters working, and our X-rays working. It has to be there 24 hours. So it's quite a lot of money. To maintain an ambulance team, you need spare parts, you need mechanics, you need products, and you need to train the paramedics. I tell you one big problem we have here. There is no, I haven't met any single Gambian paramedic who has been trained to advanced life support level in a population of 2 million people. So you have an accident in Mansakonko, Makati or Nyumi, it's a big problem. So you send an ambulance there, and the ambulance is not equipped. That's one thing. Is the paramedic trained properly to know what to do? Does he have equipment, the defibrillators, the oxygen, the suction machine, ECG, etc., to help increase your chances of survival and extricate you to the hospital? It's not available. So these are big, big challenges that we have. Just give an example. I think last week, the government gave and then requires for help of 15 new ambulances. I can guarantee you that within 3 years, they're already breaking down. Almost. Because you need to put a system. You take one ambulance, take it to, for example, Wiam. Okay, you give it to the normal driver who is there. Has he been trained to have to drive an ambulance? He's not been trained. Do you have a mechanic who is assigned properly to look after this ambulance? It's not there. The spare parts for this ambulance, I read it available for them to use. It's not there. Then lastly, the paramedic. Is he trained? They just go take somebody from your ward and say, okay, go into the ambulance and take the patient. He must be trained, he must know what to do. He must have the equipment to be able to also do that. So these are the challenges. So the government spends a lot of money. 15 ambulances, which is a lot of money. I'm talking about thousands of euros. 3 years' time, I can guarantee you they're all not working, spare parts are there, is available or not. So we go through the same cycle again and again. How can we prevent that? It's a challenge that we need to look at. I think the government is doing what it can to help the public sector, private sector. But I think it can look more on how it can help the private sector play a bigger role. I don't think we need bigger hospitals. We can provide that. What we need is incentives. It's like when you import your drugs, when you set up a solar system, when you import a generator, or you want to set up an oxygen system or ambulance service, that you are supported to get that done. And I think the private sector will continue to play a significant role in coming times, especially in areas where certain investigations need quite intensive financial financial usage. It's very difficult. So the private service could be able to use their own money to do those. Of course, but once somebody invests their finance, they expect something to back. But it depends where the government can come and say, okay, what is reasonable and how do we go about quality control? As they try and do in Senegal, I've seen they give tariffs. This is, you cannot go beyond this is tariff. Somebody comes for consultation, this is how we're going to charge them. If you want to do a lab test, this is what we're going to charge them. So we can also look into that. I think that's all for me. And
thank you very much, Dr. Jan. I think that was very useful. He was to speak before him as per the schedule. Honorable Silla and some of his committee members, like has been indicated by the president of GAFU, did a good job. For me, I don't know whether it is the first time, but I've never been impressed that way as far as the functions of the National Assembly is concerned, particularly the Health Select Committee. They did a diagnosis of the system and came up with a very comprehensive report. Some of us, like I said before, had the opportunity to read that report. But we feel, or GAFU executive feels, that this is a useful platform to also hear from the chair of the Health Select Committee of our very National Assembly. Honorable Silla, the floor is yours.
I want to start by saying that I had to urge the organizers for two reasons. One, because of time, I have a pressing, of course, another engagement to attend, which I cannot afford to miss. And also, the fact that it is important for me to speak first, so that it will set the tone. I am coming from an institution, but let me also say this. Sometimes it is very intimidating to be in the midst of professionals who are treating a subject which you do not have any training, regarding that sector, that area. But of course, I'm taking courage. My strength is I am coming from an institution that is not coming to implement, that does not implement. We are giving support. So that is my strength. So, and a very critical support at that. This is a committee that has so many sectors under its purview, not only health, but I can assure you that the passion, the interest, the efforts that this committee has for health is unrivaled in terms of the other sectors under our purview. In fact, I can even borrow the word predilection, and I learned that word from Dr. Kabir Cham in 1988. You might have forgotten. I was invited to also present at a training for members of the Gambia National Army in 1988 on, for me to give a presentation on substance abuse, prevalence of substance abuse in the country, especially with regards to young people. And then, in fact, he was trying to describe how the AIDS virus paralyzes the system. So the point of predilection. So for us, we have the predilection. Point of predilection of the committee is health. You have women. Women is there. Of course, we also give equal attention to women, children, and all the others under our purview. As a committee, like I said, we are not technicians. We are not professionals as far as health is concerned. But our role is to engage those who are the technicians, who are the professionals, who are the implementers. And this we did to the best of our ability. We did extensively in order to interrogate the system. As you know, at the end of the day, what everybody wants is to have a health care delivery system that is accessible to all, affordable to all, and of quality. So this was our motivation, this was our mandate, and we did this by engaging them. I did not read the whole, can somebody help me? The whole report, and this is a second report to a preliminary one that we did. And this is, we call it final, because it is comprehensive. It also had taken cue from the previous one, the preliminary one, but expanded. And like I said, the bias was on health, but with this report also, we decided to also add the other sectors, like disaster. But on health, you can see the committee has a statutory role, a legal role prescribed by law to perform oversight, in this case, on the health sector. And then we do this by conducting visits, having face-to-face engagements with officials, having access to reports, and after that discussing as a committee, of course, with some experts who assist us. And then this represents a fair impression of how we have assessed the health system in the country based on these facts. Facts provided by those who we had engaged. Facts provided by our visits. And as you all know, I need not say it, the health system is in a very sorry state, so to speak. It's in dire need of support, because the objective is still not met, of having an effective, as Doctor was saying, effective, not efficient in terms of operations, effective in terms of results, so that the population will have access to quality, affordable health care. We have not reached that stage yet. Through our interaction with the officials, particularly the ministry, of course, they require resources. And I can tell you, this committee had also gone the extra mile in trying to convince our colleagues, because in our interactions with them, they were requesting, in terms of resources, they were requesting for something like $1.2 billion, that this is something that they need to start off what they're supposed to do in terms of realizing the objectives of health. Of course, based on the policies, stated policies, the national development, the NDP, and what have you, in terms of guidance, in terms of policy goals. So we were able to get $1.1 billion for the ministry. For me, deep down, I am convinced that is not sufficient. But based on their request, we have been able to go this far with them. So we assume that this is something that they can start with. Of course, as has been highlighted, the challenges are numerous, but basically structural. I would agree with Doctor. And I am expecting that we need a leadership. I hope that the leadership that is in place has the wherewithal to, the political leadership to do the connection, the technical leadership that is there, the administrative leadership, to ensure that what we have given them, this report is not only narrative, this report is also practical. In fact, I would in fact appeal, if it is already a public document, it's unfortunate that we don't have any portal which you can access at the level of the National Assembly to have access to this document, but I recommend this document to be read by every practitioner, each and every practitioner in the sector. You will see our conclusions. One may not agree with us, or one cannot agree with us that it is exhaustive. It's not exhaustive. We are not pretending that we have dealt with all the issues, but we have tried to the best of our ability, based on our interactions, based on the facts that they have provided to us. It is quite comprehensive as far as that is concerned, and that the conclusions have not only touched on the medical area, we've also dealt with areas like mental health, which is an issue that also really needs the attention of the policymakers, attention of society. There's also disability, the issue of disability. We've also captured disability. As of now, there is no law on disability. And of course, for mental health, the law is since 1917. And it is called Lunatic Detention Act. Look at how would I describe that? Lunatic. You know, that the derogatory and detention, that this person is wild, needs to be restrained. And someone who is ill, who needs empathy, who needs care, he needs support. You're treating him, that is the perspective of the law and the policy makers. And that's still what obtains. So for all of us, we are guilty for having that law in place up to now. So as a committee, we have urged those from government, the executive, to really bring about a comprehensive law on mental health and also a law on disability. If you look at our conclusion, we have a monitoring schedule. These are the recommendations. Okay, can I can go down. Okay, go down, yes. Go down to the recommendations. You see, the report started with the policy context. I think you'll have time, because time may not permit me to read all. You know, we have conclusions. This is our conclusion regarding this particular area, and then we come up with recommendations. Go up. In terms of policy context, go up. So this is a recommendation. The Select Committee requests the Ministry to present a position paper to explain how it plans to respond to the demands of the public. And as I am speaking now, there is a monitoring schedule which places a reporting obligation on the Ministry, which should have started late last year. But up to now, they have not fulfilled that obligation. But for me, I'm flexible. I have prevailed on the committee to allow them time. But we really want them to, we want action. This is not a committee as we had before. I'm not sure because I was not in the assembly before, but going by the records, they have not had something like this before. Because we really want engagement. We want to engage you. We want to give you all the support that the sector requires. Within our powers, I can assure you that the committee is ready to give the sector all that it needs within our powers. But we also want the sector to deliver. We are coming to give you support to deliver. If you want partners, if you want friends to deliver, you can count on us. This I'm assuring the sector. But we really need to gather your act. Go, let's on quality of care, there's also a conclusion. Let's just go the headline so that they will see. Can we go? Is there a recommendation? Go, no. This is another recommendation. You know, maternal mortality. Like I said, in this day and age, definitely no woman should die whilst giving birth. This is unacceptable. Even if the numbers are going down, we should say no. We have to do everything possible to ensure that this phenomenon is history. As a committee, we are really encouraging officials, the ministry, to really address this issue. Maternal and child mortality, and even morbidity. Go. Go. Just scroll. Mental health, like I was saying, there is need for a law to come, a comprehensive law to come into being. And we'll be really taking the ministry to task to bring this about. And of course, I must also apologize. Like I said, the issues regarding health are so overwhelming to us that there are even some sectors within health that we could not, interrogate, like public health. We need special session to engage them. They were before us. Issues relating to public health we are raised here and there, but we need a sustained engagement to really diagnose public health as we used to know border health, the efficacy of border health, the effectiveness of border health. We want those days back. So how do we get that? How do we get that? What support do you need from us? So we need to engage you at some point. I'm hoping that this year is going to be a very eventful year in terms of engagement. For now, as a committee, we have a fair impression of what the sector is all about, the challenges. We have a fair impression of all the challenges that beset the sector. Now it's time to engage them, implement action. But I would agree that the approach, the curative approach, is not the way forward for Gambia. Primary health care, as they have said, is an approach that needs to come back, enhance, give it all the support. But for me, preventive health is really the way forward. You are the actors, you are the operators, you are the ones given the responsibility to implement. But as a committee, as a representative of the people also, I believe that we need to change the thrust if we really want to ensure that we have a healthy society. Can we? Disability, yes, it's gone past disability. Yes, disability, like I said, yes, it's also an issue. Of course, we have a main referral hospital, Edward Francis Small Teaching Hospital, which is university, which is academic related, with trained doctors, practitioners in the sector. But in our interactions, we have realized that the processes that are needed to be in place are not there for a teaching hospital. All the departments that are needed, they are not there. So these are challenges, so they need support. In fact, this budget that I was talking about does not even factor Edward Francis Small Teaching Hospital. As a committee, we have to request from them to tell us how much they would need to have a fully fledged teaching hospital, university teaching hospital. And they have done that. And I believe that in our subsequent engagements, we will be trying here and there to see how they'll be supported to have those resources that they need to provide what they're supposed to provide under law. And then, yes, of course, the law has prescribed their role in terms of training doctors. Also, the issue of accreditation, I understand, is a challenge. Those that are training them, there are issues of accreditation. So, and because resources are really needed for the Edward Francis Small Hospital, and the committee has taken note. Okay. Okay. Let's go down. And my apologies, I'm sure the presentation is very boring. Go down. Go. Just go down. Let's go to the monitoring schedule. Because I'm sure most of you have had access to, had gone through this report. Yes, this is what the committee has tasked the ministry to do, and we'll be monitoring it. And this is started last year, the last quarter of 2018. We tasked the ministry to provide a detailed roadmap on the implementation of the compact for coordinating donor support. As you know, all the resources that are required by the sector are not coming from the GLF, what they call Gambia local funds. There's a part that is coming, like the support being given to NAS. Axonet is also coming through that. There is an axis there that is coming in terms of global fund. The EPI is being supported by Gavi. And those interventions, WHO is also coming, giving support. So all these are coming in terms of, in both kind and cash, so which augments the resources that are coming from the GLF. So as a committee, we want to know what all these financial issues are, so that we'll have an idea as to what is needed, and then how it is being utilized. So we have requested this roadmap, a detailed roadmap regarding the compact. We have also requested the ministry to provide a comprehensive health assessment report. And all these things are outstanding, as I said earlier. Resubmission of the disability bill to the National Assembly, submit study report on the design of the health insurance scheme, provide data on trends 2014 to 2017 on the total number of non-communicable diseases, NCD, cases seen in an outpatient's age 15 years and each NCD as a percentage of the total number of outpatients aged 15 years and above, provide data on the number of cesarean sections carried out in the major health facilities compared to the total number of deliveries in 2016 and 2017, to give us a comparison to see whether things are improving. Provide electronic copy and hard copy of National Standard Treatment Guidelines 2017, collect and compile lists from Ministry of Finance of agencies, individuals under the Ministry of Health that did not receive their personal emoluments and allowances from 2013 to 2017, like the Medical and Dental Council. There are outstanding payments dating back from 2013 to 2017. And when allocations have already been approved by the National Assembly. So we want to know why. Where has those funds gone to? Had they been released? So these are all issues that we have requested the ministry to provide to us. I know the chair is of course in a hurry. So basically this is what we have been asking from the ministry. Like I said, for the last quarter is outstanding. We haven't received any response. And I guess Mr. Judge is here, Jibril. Jibril, I'm not going to, it's not that I'm pushing, but perhaps in my absence, Jibril may tell you how far they have gone with this. But we are being, like I said, I don't want to use the word lenient, but we are being we're flexible. So we have, hopefully before the end of the month, we will hear from you. We'll be starting our engagements by next week. So we'll get back to you officially, and then we're expecting you to explain to us why these reporting obligations have not been fulfilled. So basically, this is it, and then, like I said, it goes for the whole year, from January to December this year. It's what we have done. So any one of you who does not have access to this copy, I think you can consult with Mr. Juf or even Mr. Judge Jibril. They have access to the copy. But I would advise that you take the one given to Bala, because there is an intervention he made which was not factored. It was attributed to a different official. So this one is rectified, so you can share it now. So this is the official one. I do not send it to you. Okay, so you can use that one. So on that note, this is what I really wanted to. Although I don't present it the way I wanted to, but I guess you've got the message that it is an institution that has the powers to allocate resources to the sector. It also has powers to ensure that the sector delivers, the public sector. In fact, it's overall, because even the private sector, we have leverage over everything within this confines of the Gambia as a community, as far as health is concerned. But like I said, we are not engaged in any confrontation. We are partners, and I'm assuring you that we are always ready to give you all the support that you need. We just want you to deliver. At the end of the day, for us as a committee, we want to have a legacy. And for this year, we want at least 2 pieces of legislation to come in place. That is mental health law, we want it this year. We also want the disability law this year. And of course, any other law that we can work in partnership to bring about. So thank you very much.
Dreaming of owning a property in a prime location with great proximity and fantastic neighborhood? EJ Investments Sanyang Seaview Estate is the best choice you have been waiting for. Our Sanyang Seaview Estate is approximately 15 minutes drive away from the busy hub of Brusubi roundabout and into the heart of nature, where you can have a peaceful and relaxed lifestyle with your family. You can buy a finished 4-bedroom story with 5-year flexible payment plan, or a service plot with 2-year payment plan option. With over 300 homes, you will enjoy big tar roads with covered drainage, modern electrification with solar street lights, gated entrance with security post, and a breath-catching experience of our beautiful sea view and lake view. You can own a home today at our Sanyang Seaview Estate. Call us today on 446-4838 or 325-9220. Visit our website on ejinvestments.net. EJ Investments, first in property.